Hello, everyone. I want to start by thanking all of our viewers and welcome you to Medical Student Grand Rounds. I am Bryce Ringwald, fourth-year medical student, vice president of Student Council. Medical Student Grand Rounds is a lecture series that is given by inspiring medical students. This series occurs on the first and third Tuesday of the month, starting at 12 p.m. and is conducted via Zoom using the same link every single time. Today we have a fantastic presentation lined up for you. Charissa Newkirk, an aspiring psychiatrist, is going to be presenting to you about the history of mental health in the Black community. And then on March 2nd, we're going to be hosting a special State of the Education address given by the Medical Education Dean staff. They're going to be updating us on progress that's been made over the past years, changes to the curriculum, changes to student life, and then also talking about kind of the future trajectory of the College of Medicine as well. So we're excited to have them kind of update us on, where we are as a college and where we're going. We also want to make you aware of our YouTube channel, where you can view all of our past presentations. To do this, go ahead and log into YouTube. And then you just search Medical Student Grand Rounds, and then be sure to subscribe to our page to be able to follow along all the different presentations that we've been lining up for you all. During this talk, we're going to be utilizing the QA function for questions at the end throughout, and feel free to put in questions as you go. We will do our best to kind of get to all of your questions that you have for Charissa. And now, without further ado, it is my great pleasure now to introduce Dr. Tamar Gur for today's introduction.
Thank you so much. I'm excited. It is indeed my honor to introduce soon-to-be Dr. Charissa Newkirk, who I believe to be an embodiment of excellence. She strives for and achieves remarkable accomplishments in every single possible realm. Her academic pedigree is a remarkable launching point for this individual, just a rising star. She's here originally from Dublin and graduated from Dublin, and I'm not going to pronounce it right, Scioto High School, before going on to graduate from one of the most toughest and most rigorous colleges in our country, the University of Chicago, where she repeatedly made the dean's list while becoming a varsity captain. She's a sprinter. She's actually kind of a marathoner academically, but in track, she was a sprinter. And not only that, she managed to find time to just do remarkable research at an undergraduate level at that institution, as well as here as part of our Success program here. Her ability to excel in multiple arenas of her life continued on here at Ohio State, where she's received a prestigious MDSR fellowship to conduct research. And I was lucky enough to have her in my lab, bringing her knowledge and her passion to my lab to look at the effect of stress on maternal behaviors. And let's see, my screen just changed. No, I'm still here. And she's also gone on to be a member of the Gold Humanism Society, the AOA Task Force. She's been elected to Student Council, and she was the co-creator and co-teacher for an underclassmen course titled Introduction to Medical Ethics and Professionalism, the Experience of the Black Person in America. And the advanced elective for fourth-year medical students as well. Phew, I'm exhausted just listing her many accomplishments. And I am personally and professionally thrilled that she has chosen psychiatry as her specialty, to which she's going to bring this tremendous experience, brilliance, and aptitude to fulfill her potential, which I think is my very favorite definition of success by Maya Angelou, to do what she likes and fulfill her potential that way. So without further ado, I'm thrilled and honored to introduce Charissa and her talk today, Mental Health in Black America.
Thank you so much for that introduction, Dr. Gur. I really appreciate it. Hello, everybody. I'm Charissa Newkirk. I'm an M4 at the college, applying into psychiatry this year. And I will go forward with my talk. So mental health in Black America. So just a brief outline. I want to just go over some of the basics as we begin to look at the literature through a racial and inequity lens. Further discussing, generally racism in medicine and why it matters, then getting into mental health disparities within the Black community specifically, and then next steps that the medical community can take to be better allies and address some of these disparities. So I kind of want to go over first some basic just definitions. I know that as the Black Lives Matter protests have happened over the past year, there's been a lot of articles about race, and going through those, notice a lot of different terminology that might be confusing to some people. So I kind of wanted to go over that first. So when we, talk about the Black community, there's different, I guess, kind of sections. So when we talk about African Americans, it's specifically Black people who are born in the United States, and more specifically those who come from the enslaved people of the United States. Whereas using the term Black, it's a more general term that includes anyone of African descent, including Indigenous Africans, African Americans, Caribbean Black people, and immigrants. People of color is a bigger umbrella term even over that, to include all non-white ethnic and racial groups. Afro-Caribbean focuses specifically on people of African descent living in or coming from the Caribbean. And then BIPOC is kind of a newer term that's come up over recent years. That means Black, Indigenous, and people of color. So, why do I say this? I think that it's important that we get used to using the term Black. It represents a shared history and identity, not just skin color alone. It's more inclusive and non-specific, so it can be used in a variety of contexts. The caveat here is that not everyone who identifies as Black has similar experiences, and the Black community shouldn't be treated as a monolith. And I think this is especially important when we look at research into Black Americans, that there are people who may come from Africa who are African American, or first generation. We all have different experiences, and so we have to look at these statistics critically and think that Black Americans are not a monolith. And people of color, while it's an all-encompassing term, it doesn't replace the opportunity to identify someone as Black if someone identifies themselves as such. So more things to consider when we're looking at the literature in relation to Black patients. So when we examine Black Americans in research, how much is historical context considered? So I give the example of food deserts. It's well known that Black patients have higher rates of coronary artery disease, for instance, or hypertension. And thinking about critically whether this is due to some biological difference or whether it really is due to systemic barriers due to racism that keep Black Americans from, for instance, having a healthy diet, the ability to exercise, the ability to access care. And then furthermore, do studies delineate differences between different groups within the Black community? So like I was saying, we can't treat the Black community as a monolith. A lot of times this data is not disaggregated between immigrant populations versus African Americans, or even sex differences between Black patients. And then, how much do we differentiate between economic versus racial disparities in research? Oftentimes these two are conflated just because, unfortunately, there are a lot of Black Americans in poverty, but race and economic class should try to be differentiated whenever possible. So with that kind of background, I want to go into, a background about racism in medicine in general. So I want to make it clear that it spans across all fields and that it goes back to the times of slavery and then goes into the present and has persisted over this time. And I think it's important to consider the role that medicine has played in actually contributing to these health disparities seen across the Black community. So examples including vaccines, which is a hot button topic right now with the COVID vaccine, medical algorithms, et cetera. For instance, with pulmonary function testing, race is actually a factor that is included in the pulmonary function test to determine whether someone has asthma, for instance. And then thinking about the effect that racism has on patients as well as providers. So, I kind of included these corny looking pictures here, but, for instance, as a Black female in medicine, what is it like walking around in the hallways and seeing just white faces on the hall? What does that do to a person's psyche? Or, maintaining a level of professionalism when you see people, for instance, like in this picture, who are wearing Confederate flags, wearing hate symbols towards Black Americans. How does that impact the provider? And so I think it's important to consider all of these things when we're talking about racism in medicine, and not just looking at health disparities from a systemic standpoint, but then looking inward into medicine itself. So I want to go over, just a couple of examples of racism in medicine that have come up a lot over the past couple of years. So for instance, in OB-GYN, Black mothers in the US unfortunately die at 3 to 4 times the rate of white mothers. And these disparities exist even when comparing Black and white mothers of the same comorbid conditions. And this is further emphasized when looking at a different study that showed Black and college educated mothers who gave birth in local hospitals are more likely to suffer severe complications compared to white women who never even graduated high school. So even taking away socioeconomic barriers or social capital barriers, race specifically alone was a determining factor in whether someone had severe complications. And then the lifelong accumulated experiences of racial discrimination by African-American women constitute an independent risk factor for preterm delivery. This effect actually was shown to be even stronger than alcohol use or access to early prenatal care. It just shows how deep racism runs in medicine. And so I put this picture here as well, talking about Dr. Sims. So, Dr. Sims was considered the father of gynecology. There was a speculum named after him, but he was known for performing surgeries with no anesthesia on enslaved Black women. And it's just an example of how things that happened so long ago, even within medicine, still have effects today on building mistrust within the Black community, or distrust within the Black community, as well as having poor outcomes for Black women. Cardiology is another example. So like I mentioned earlier, Black patients continue to have the highest rates of coronary artery disease mortality among all ethnic groups in the United States, despite there's been an overall decline of cardiac or coronary artery disease related mortality among the general population. And thinking about, why this is, so Black patients, like I alluded to earlier, continue to have a higher prevalence of risk factors that lead to coronary artery disease, diabetes, hypertension, et cetera, compared to white patients. I'll remind you before about what was mentioned before about naming statistics like this. So it's important to think critically why Black patients have higher rates of this, hypertension, obesity compared to white patients. There's been a historical lack of access related to nutritional foods, redlining lead to crowded housing conditions. Those all contribute to these statistics. And then I want to note as well, there's racism-related vigilance, which is actually chronic stress as a result of anticipation or perseveration on racial discrimination. So because of this, Black patients with the highest vigilance levels actually showed an increased likelihood of hypertension compared to white patients. So racism alone and the anticipation of racism has physical negative health consequences. And among patients presenting with acute MI, or heart attack, Black patients are less likely to be admitted to centers with revascularization procedures available and centers with high quality acute MI outcomes. And this just shows that Black patients, even when life-threatening situations occur, they're less likely to have access to these centers because they're usually not placed where Black and brown communities are located. So with all this in mind, I think it's important to recognize that psychiatry and mental health are not exempt from this examination of this research through a racial lens. We need to reckon with how our profession has contributed to racism within the psychiatric population, what disparities exist now, and where to go from here. So I'll be going over, this kind of history and the impacts of stigma, and then kind of looking at subsects within the Black population, such as children and adults, and then examining police brutality. So a brief history of psychiatry in the Black community. So in 1853, there was a physician named Dr. Cartwright, who was a Southern physician, and he began diagnosing enslaved Black people with 2 mental disorders. And I'll try my best to pronounce these, drapetomania and dysethia ethiopica. So drapetomania was defined as a mental disease that causes a slave's discontent as a laborer and attempts to run away from their master. This was an actual diagnosed disease. And dysethia ethiopica was described as a mental illness said to cause Black people to act lazy or mischievous or feel no pain, obviously all in quotations. And this was described as the natural offspring of Negro liberty. It was just a generally held belief at the time that many enslaved Black people were, quote, immune to mental illness as they were not exposed to the stresses of the working world. And if you think about who was working at the time, it was white men. So what they were thinking at the time was that Black people who were enslaved were somehow immune to this, to mental illness, and that if they were diagnosed with it, it was either of these two disorders. In 1840, there was a rise of the asylum movement. So essentially building asylums for mentally ill patients and trying to take care of them there, at least in northern states. Unfortunately, many southern states did not build mental health facilities until well after the 1840s had passed. And even those that did exist didn't accept free Black people or enslaved people as patients for most of the plantation era. So these people continued to go untreated. Flashing forward a little bit to the 1880s, there was a physician named Dr. Powell who said that emancipation was causing African Americans to become insane because they were no longer under, quote, the hygienic effects of slavery. Using this he used this, I guess, logic to justify a rising Black population at the time in a particular asylum, when actually it turns out that that population had a high level of tuberculosis and pellagra, which as physicians, we both know can cause a lot of neurological distress. So when Black patients were institutionalized, they were even further, they were segregated from other patients, they were put in poorer conditions, and oftentimes they were actually made to do manual labor to essentially recreate slavery conditions as a form of rehabilitation. Jumping ahead even further. So, asylums stayed like this until the 1960s and 1970s, where Black patients remained segregated. So in 1964, the Civil Rights Act was passed, and Title VI of the Civil Rights Act declared it illegal for any facility or service receiving federal funds to discriminate on the grounds of race. The Civil Rights Act may have passed in 1964, but that doesn't mean that people agreed with it or were willing to follow what the Civil Rights Act was saying. So jumping ahead to 1967, the Office of Equal Health Opportunity actually inspected facilities in the South and found that a lot of psychiatric hospitals were still operating in breach of the Civil Rights Act even years later. So I put a quote from an inspector here that essentially there were only 5 physicians, none of them were qualified. In fact, one of them wasn't even a physician, and they made note that it seemed like they were running a Southern plantation. So states such as Mississippi and Alabama chose to actually fight the federal court and fight the federal government in court, claiming that it was their right to run state services free of federal interference, and that it was, quote, medically necessary to segregate patients along racial lines. So again, just because the Civil Rights Act was passed doesn't mean that people followed it or even considered it important. And then in the 1970s, psychiatrists added the word aggressive to the definition of schizophrenia. And you might think back, what was happening in the 1970s and the late 1960s was the civil rights era. So many activists considered this to be a targeted response towards the civil rights movement. And because of this new definition, there was a big push by pharmaceutical companies to market schizophrenia and like antipsychotic drugs towards Black patients who they felt were more, quote, aggressive or out of control. So then where does that leave us currently? There are many studies that demonstrate that Black people generally have lower lifetime risk of psychiatric disorders compared to white patients. However, there have been studies that also show that the Black community has a higher incidence of schizophrenia specifically compared to the white population. And furthermore, Black patients that are diagnosed with schizophrenia are overrepresented in the state psychiatric hospital. And those who do become ill tend to have a more persistent, severe disease course. It says a lot about how we treat Black psychiatric patients when they're hospitalized and seek treatment, in that there is a pretty long delay between onset of illness and actual treatment. In fact, serious mental illness rose among all ages of Black and African American people between 2008 and 2018. So why do we continue to say that that patients have Black patients have a lower lifetime risk of psychiatric disorders when there's data to prove otherwise? There's evidence from some studies to show that clinicians overdiagnose schizophrenia in Black patients, but then underdiagnose mood disorders in Black patients. You may just remember one slide ago how there was an uptick in the 1970s of Black patients being diagnosed with schizophrenia. That problem clearly never really went away. So the problem is still persisting today, even though it was many years ago. And then generally, racial minorities tend to have less access to mental health resources compared to white patients. So for instance, among adults with diagnosed-based need for mental health or substance abuse care, 37% of whites, but only 25% of African Americans actually receive treatment. So again, thinking about earlier, we discussed studies through a racial lens. We have to think about why Black patients aren't receiving treatment, even though they're diagnosed with a mental health condition. We have to think about the systemic racial barriers that Black patients are facing. For instance, like I mentioned earlier, medical centers that are not located in underserved areas, criminalization of drug and alcohol use in Black patients compared to white patients who are often rehabilitated, et cetera. And then if you need more reasons as to why Black patients are not receiving mental health care, compared to white patients, Black Americans are less likely to receive evidence-based care, less frequently included in research, and more likely to use emergency departments or primary care physicians rather than mental health specialists. And when Black patients are treated, they're often treated at higher doses that lead to more side effects, and rather than newer, more evidence-based medications. So I want to take a second to talk about stigma. Stigma is a major issue in the Black community when it comes to seeking care within the mental health space. So some phrases that are often thrown around of people saying it doesn't happen to us, or we're strong, we don't get depressed, or just pray it away, or that's a white people problem. You know, do these sentiments sound familiar? They may sound like the sentiments perpetuated by white people during slavery, that Black people are somehow immune to these sentiments. And unfortunately, these kind of sentiments have been internalized by the Black community and perpetuated over many, many years and still persist today. And this is just another huge barrier as to why people are not receiving care. And I think it was worth noting. So I want to get into subsections of the Black population and kind of what mental health looks like for these folks. So thinking about specifically Black children and adolescents. So there are many identifiable risk factors for mental illness that disproportionately affect minority children, such as poverty, food insecurity, exposure to violence, et cetera. It's a reoccurring theme that minority children, unfortunately, have higher risk factors of all these things that later lead to poor health outcomes. And there was something that I read too that I thought was interesting, the term compounded community trauma. So children that witness violence both in their homes and in their neighborhood actually have higher risk of mental health disorders. And oftentimes these are experienced by a lot of racial minority children. So I wanted to point out as well that there's high rates of serious emotional disturbance among youth in the juvenile justice system as well as the child welfare system. These systems have high percentages of racial minorities such as African Americans, but oftentimes they aren't receiving the care that they need because they're often just labeled as aggressive or having behavior problems and get punished without having a more thorough investigation as to why these behaviors are occurring. And a lot of times it's because of mental health disturbances. And I really like this diagram and wanted to include it because I think it kind of shows the interlinking between trauma, mental health, and the different environmental factors that contribute to those. So for instance, taking a Black child who has poor housing conditions, has food insecurity, lives in poverty, that is going to create chronic childhood trauma. And any good psychiatrist knows that trauma early in childhood those people have a high risk of developing mental health disorders later down the line. So that person, say they develop a mental health disorder, this leads to poor academic achievement throughout school, which then leads to a decreased social capital and puts them right back in the poverty that they grew up in. And these physical and mental illnesses will persist over time if left untreated. And so if that person has a child, it leads to an unstable home environment and the cycle continues. And so, you know, on the sides, these are ways to intervene would be, you know, through school-based health centers with mental health services, increased access, increased utilization of mental health systems. Those are things that can be used to kind of break this cycle. But unless those things are put in place, the cycle will continue. And I really want to emphasize as well the idea of trauma-informed care and really making sure that we are taking thorough histories as physicians to really tap into the trauma that someone might have that may lead to their behaviors later on down the line. Now looking at adults specifically, so when it comes to Black men, so African American men have death rates that are at least twice as high as those for women when it comes to suicide. And poverty, racism, and trauma are all primary contributing factors to mental health disorders in African American men. These again are all risk factors that arise due to systemic racism and structural barriers that oppress the Black community. I also wanted to share a quote that really taps into the psyche of a Black man in the United States. The study that looked at this, they had a focus group and shared some of the quotes that these Black men shared. So one person shared, "How would you feel if you thought everyone around you was afraid of you or thought you were getting ready to do something illegal?" I think this really sheds light on how chronic racism in of itself can lead to negative health consequences, and in turn can lead to someone fearing seeking out care later down the line. This is compounded by the pressure as well for a Black man stereotypically to try to be a provider for his family. And when that goal seemingly cannot be attained, it can further spiral into a depression. But again, a lot of these folks don't know where to turn to for help or feel a lot of shame about it. And looking at Black women, so African American women reported higher use of religious coping mechanisms compared to Hispanic, non-Hispanic white patients. But intimate partner violence, discrimination, and a negative neighborhood environment are important predictors of a Black woman's mental health. I think that there's a lot of conflicting statistics like this that show Black women being, quote, resilient and having strong social supports, while at the same time they are at really high risk of developing mental health disorders because of the conditions that they live in. So I think it's really important to practice cultural competency here and understand that while someone may use prayer as a coping mechanism, that doesn't mean that there isn't something deeper underlying, or that somehow that is worse than trying to obtain medication. And I think it's important that we don't continue to perpetuate the Black women are strong stereotype. Black women unfortunately have high rates of experiencing intimate partner violence, discrimination, et cetera, that lead to poor health outcomes. And so we can't continue to perpetuate this stereotype. And because of this stigma, Black women, utilize mental health services less compared to white patients. Again, this might seem like, oh, Black patients aren't utilizing as much, so maybe they aren't needing it as much, when really there's all these invisible barriers that are prohibiting someone from seeking care. And then I wanted to touch on the LGBTQ plus population as well. So LGBTQ folks, it's no secret that there's an increased risk of mental health disorders within this population specifically. And they're more likely to have risk factors that can lead to mental health disorders down the line, such as homelessness or unemployment. But LGBTQ plus people of color specifically have increased suicidal ideation and increased risk of attempting suicide because of this compound multifaceted discrimination. And then multiracial transgender people specifically experience disproportionately higher levels of attempted suicide, poverty, unemployment, and unfortunately, they are often victims of violence. And I think we've seen this a lot over the past year, unfortunately. And so it's really important that, we try to uplift these communities. Now, I want to touch on police brutality because it's been a hot button issue over the past year, but because of psychiatry's role and the crossover between the criminal justice system, the police system, ethics, et cetera, I think it really is worth noting here. So police killings of unarmed Black Americans have adverse effects on Black mental health. Young Black males that report more contact with police also report more trauma symptoms and anxiety symptoms, and those associations were tied to how many stops they reported, the intrusiveness of the police encounters, and their perceptions of police fairness. People with mental illness, especially those who are Black, are disproportionately at a higher risk of dying by police killings than the general population. And so you kind of see this cycle similar to what we were discussing when we were talking about Black children, that repeated lack of access to resources, decreased social capital leads to chronic stress and mental health conditions, which can then lead to unstable living conditions and violence. This leads to increased police surveillance, which heightens mistrust within the community and exacerbates chronic stress, which then leads to disruptive behavior, and the cycle continues, leading, unfortunately, sometimes to an increased killing of Black psychiatric patients by police, and police are not as experienced as mental health professionals when dealing with someone in crisis. And then I also would be remiss if I didn't mention, further the court system and incarceration, because we do take care of a lot of people who have been incarcerated in the past. There's a strong association between mental health symptoms, race, and the criminal justice system extending into the court system and incarceration. Racial minorities already experience disadvantages that lead to increased risk of mental health issues on top of concentrated criminal justice contact within minority communities. It sets up a recipe for poor negative health outcomes. Incarceration in and of itself leads to stress and trauma, as well as the complex situation that arises when a person is freed from prison and must now reintegrate into a society, while also still potentially being monitored by the criminal justice system, for example, through parole, even after they're released from jail. So all of these factors contribute to negative mental health outcomes. And I actually want to do a small plug for a podcast I've been listening to recently called Decarceration Nation, that has a host that was incarcerated himself. And they kind of discuss, the stigma even within the prison system. If someone finds out that you have a mental health disorder, that is a target on your back if you are an incarcerated person in prison. And even though these people are getting access to healthcare, depending on what's on formulary and depending on who is taking care of you, you may not be getting the best quality mental health care at the prison system. Or you might be prescribed something in the hospital and then go back to prison, and then all your medications are changed. This happens a lot within the healthcare system. And so, this happens to anyone with mental illness in the prison system, regardless of race, unfortunately. But as we know, Black people are disproportionately represented in the prison system. So it's going to naturally affect that population more. I think it's just a good example of a vulnerable within the vulnerable type of situation. So Black prisoners with mental illness experiencing repetitive racism, trauma, and exacerbation of mental health symptoms. So all that being said, I think it's important to think, okay, well, what next? So hiring more Black doctors, I know that seems overly simplified, but it really is true. Evidence demonstrates better patient care. So increased engagement with patients, increased medication adherence, consent, more consent and shared decision-making when Black patients are paired with Black doctors. Unfortunately, only 5% of all active physicians of all specialties are Black. And I looked it up, and there's only about 7% of psychiatrists are Black, which is still higher than 5%, but not great, considering the fact that Black Americans make up 13% of the population. Hiring more Black doctors will contribute to current Black physician wellness to have more Black doctors enter the workforce. There's a lot to be said for providing safe spaces for Black people in the workforce, and it's helpful to recruit Black physicians, but the effort is lost if this cannot be retained. So this is one technique to ensure preservation of Black people within the workforce. And then diversifying the workforce benefits non-Black physicians and trainees as well. Sharing cultural values and learning off of each other creates a better working environment for everybody. So access, I've said it a lot during this presentation, but I think it's really important that we have better access for people who are within these vulnerable populations. So the rise of telemedicine within COVID has been a good thing overall, I would say. The pros being that it removes the transportation barrier to have to get to appointments and get medications filled. So you can see a doctor that may be really far away, just at the touch of your hand with a phone. But the cons is that it requires reliable Wi-Fi and or phone access, which if you're somebody that has unstable housing conditions or is homeless, that might not be a possibility for you. So integrating telemedicine, but trying to address some of those barriers as well. And then working within a hospital system that incentivizes practicing in underserved communities. As you can see, not having access to a provider in these communities is a problem and leads to later diagnoses that then lead to a more severe disease course. I did just a quick Google search. If I was a patient and needed a psychiatrist in Columbus, Ohio, these are the places that come up. You might think these places are predominantly white places, and you would be correct. Besides Hilltop, all of these are predominantly white areas. And so, how is someone, for instance, in like Whitehall supposed to get access to care when all of these psychiatrists are not anywhere near them or may not look like them? So it's a huge barrier. And I think larger hospital systems honestly have an obligation to try and reach out to those communities. And then having interprofessional and comprehensive care to ensure that a patient is linked through the proper channels. So it's not just psychiatry that needs to be checking out on the patient. It should be social work, it should be case managers. If a patient doesn't have a case manager, they should really get one. If they have multiple different appointments with multiple different providers, or someone that has trouble keeping up with these appointments, or may have a unstable housing situation, or unstable housing situation, that they should have access to a case manager. And then therapy as well. Having a psychiatrist and a therapist, I think, is truly essential. So having multiple eyes on the patient's really important. Obviously, you know, there are cost barriers to that, but the more comprehensive care the patient has, the better. And then, you know, I mentioned police. Again, psychiatry is a medical field, has more interactions with police than any other specialty. So I think it's really important that we address this and reflect how psychiatry, law enforcement, and Black patients all interrelate and what can be done to improve these issues. So, you know, some examples would be more research into police force, specifically with mentally ill patients, and the role that psychiatrists play in this, and how psychiatrists can kind of mitigate this risk of lethality. Quality improvement measures to potentially reduce use of police and security within the hospital setting, demilitarizing security and law enforcement that handle mentally ill patients in a hospital setting. So trying to reduce these security guards from having like guns or other things that can be weaponized against these patients. And then increase education for all parties that handle mentally ill patients on de-escalation techniques that do not involve force. And I cannot emphasize this enough. I think that de-escalation techniques are good regardless if you're a psychiatrist or from another specialty. It's imperative that you know how to handle somebody that is dealing with a mental health crisis, because it can happen at any time, anywhere. And I wanted to highlight, you know, community changes. The question of, should we call the police for those in mental health crisis? So there actually is a program called the Denver Star program. I got this picture from NPR that kind of highlighted them. So the Denver Star program, it stands for Support Team Assistance Response. So over the first 6 months since June, this is most recently updated. I just read this article a couple of days ago. That over the first 6 months since June, Denver received more than 2,500 emergency calls that went to the STAR program, and the STAR program was able to respond to 748 of those. And of all those calls, there were no calls that required the assistance of police, and no one was arrested. So trying to make sure that there are people that can properly handle, whether it be mental health situations or just unstable living situations rather than police, it's been shown to work. So increasing social workers and other mental health care providers that can reach out to people on the street and kind of prevent this, this escalation with police from happening in the first place. And then I wanted to put this on here for anybody that is in Columbus or Ohio in general. I found this on Instagram, but I think it's really helpful just to have numbers on hand that are not 911. So NetCare, for instance, is a mental health and substance abuse crisis hotline. So these folks will come in and check on a patient who may be experiencing a crisis at home and determine whether they need to go to the hospital or not, and can guarantee that they get admitted in a timely fashion without having to necessarily use only police. So that's just one example. There's other numbers on here as well for specific areas around Columbus, but I think it's good to have on hand, so screenshot it if you want. And then finally, being an ally, reflecting on ways to combat racism within your own life. So thinking to yourself, in what ways have I engaged in the rhetoric that promotes othering or stereotyping of Black people? What can I do to better educate myself on the historical context of race in the country and community that I exist in? And then engaging in other non-Black friends and family in these conversations. I cannot emphasize enough how much it's important that Black people are not the only people educating people on this topic, and that it's more meaningful when non-white people engage other non-white people in these conversations. Taking in more anti-racist media. I threw in a couple of books here that have been critically acclaimed by multiple people. They're more medicine specific, but just thinking about who you're following on social media, what kind of movies you're watching, what kind of books you're reading. Are they promoting anti-racism? And there's a plethora of different resources out there for people that are interested in learning more. It's just, you have to take the initiative to find it. And then supporting Black culture. So investing money into the Black community in your daily routine, whether it be through restaurants, through stores, what have you. Having more sustainable initiatives rather than bursts of activism only during a time of crisis is important, so that we can sustain mutual aid for this community that's been oppressed for so long. There's Instagram pages. There's like a Columbus Black owned page on Instagram that I follow that has anything from restaurants to clothing stores that are Black owned. And then there's multiple websites that now show Black owned businesses. I think Google did it for this month, for Black History Month. And then Yelp actually has its own section of Black owned businesses for any of you who are foodies. So it's really easy to do, just to try to implement into your daily life. And then, obviously donating to initiatives that support Black communities directly. And then, when there are times of crisis in our country or in our local communities, checking in with your Black friends, family, and colleagues. And honestly, it shouldn't just be when these instances occur, but just supporting them always is truly, truly important. Just knowing that someone else is there to be an ally, and not just performatively, but consistently. So I included this last slide because I think it's important to understand that this is more than just our patients. These are people that we are interacting with on a daily basis, whether it's the person bagging your groceries, whether it's me in a white coat. Racism is everywhere, and it's important that we address it now and understand that it perpetuates beyond just inside the hospital. And so, this is me. The picture on the left, the black and white one, is from the Black Lives Matter protests, and then the one on the right is when White Coats for Black Lives did a kneel in honor of George Floyd in front of the James. Obviously I'm very passionate about this, but it takes more than just one person. And I really just want to emphasize how important it is to just be committed to this cause, and that you could really change someone's life just by, educating yourself and being an ally for somebody else. These are my references, more references. Okay, and I will open it up to questions.
We already have first of all, great job. Let's take a moment to applaud. That's just a phenomenal job. And I have some questions, but it looks like our attendees are already putting some in the chat. So please take a moment if you have a question. I will make sure that it gets answered.
I will go back to the QR code too for questions.
Yes, I think that would be great. But while you're doing that, I'm going to go ahead and read the question that we already have in the chat. Yeah. Which is, how do you go about finding an African-American psychiatrist in the community? Where should someone start?
That is a good question. So obviously, I will say within Columbus, because that's mostly where my experience has been. There obviously is there's Riverside, Ohio State, and there's other communities like freestanding psychiatric hospitals. But I've found that community centers such as North Central and Southeast tend to have more connections in Black communities. So, and OSU at least connects with them a lot, and they have really good providers there, and they can provide pretty comprehensive care. So if someone is interested in seeing a psychiatrist in Columbus, I would definitely start there.
That's great advice. Let's see. So we answered that live. Is there any other questions coming in the chat? While we wait for more questions, I couldn't help but there's a lot to touch on. The one thought is that we are doomed to repeat history if we don't study it. So I really appreciated you going into the ugly history of psychiatry as it pertains to Black history and the continuing ongoing issues. Another problem that I don't know if in preparation for this, I think you touched on it, but what is the situation in terms of research into this issue? Is NIH doing a good job? I kind of know the answer, but how is NIH addressing this, or how is it not addressing it? What do you see as, important?
Yeah, that was something I noticed in preparing for this, was that just the lack of research is ridiculous. And or even especially recent research. I tried to pull up things that were more recent, but it's sad to see when you just type in, race, like Black mental health, like in PubMed or whatever, that it's articles from like the 1990s, you know, like why is this not being researched? Why is it not being funded? And then it was even more difficult for me to parse out, you know, okay, what about LGBTQ plus people of color? What about women? It was really hard to parse that out. And then, like I was saying, when I was talking about Black women, I often saw this conflicting data of, well, Black women are really resilient. They have social support, they have prayer, they have all these things, but then seeing all the risk factors that Black women have, especially those in lower income communities that set them up to unfortunately be victims of violence, have mental health issues down the line. I wish it wasn't so conflicting. And even within the research, it just seems like these stereotypes are just perpetuated over and over again.
Yeah, and additionally, there's another issue with NIH is that it's not funding Black scientists enough. And so I think it makes sense that that's like another area that NIH could improve, is not just funding research into these topics, but funding Black scientists. There's a clear disparity between the time it takes Black scientists to get their first grants or the rate at which they succeed in getting grants. And so I think those are two key ways that NIH could do a better job. We have some questions coming in though in the chat, and I want to make sure you have a chance to get to them.
Okay.
There's a bunch. You guys are doing a great job. So phenomenal job is the comment. As a Black medical student, I struggle with preserving my mental health and staying connected with present day anti-Black atrocities. Any advice on how to find balance?
Oh, that's a tough one. That is a tough one. Honestly, I think, for one, accepting that it's okay to seek out help if you need it, seeking out therapy, seeking out a psychiatrist. I mean, that is number one, just accepting when it's out of your hands and you really do need help from somebody externally. But I think also just surrounding yourself with people who can advocate for you is so deeply important, and people who are not just going to be there when these crises come up, but who's going to be there 2 months, 6 months after the fact, still showing up for you for the things that you care about, for these instances that happen. You know, I've experienced racism from, you know, patients, and how do I reconcile that? And, you know, who are going to be the people that check in with me after those instances happen? Luckily at OSU, you know, the community has been wonderful, personally for me. So I haven't had issues, but I'm sure that there are issues within other hospitals, other healthcare systems, of finding those allies. So I think, I don't know, to me, that's the most important thing.
Yeah, that's great advice. Justin Mitchell is asking, how can we increase the amount of medical students who are both interested and dedicated to improving mental health in Black communities? Oh,
that's a good question. I mean, for recruitment and retention, I'll say it over and over again, really calling on hospitals to recruit more Black physicians, and doing, you know, looking at the research like this and saying that there is a need for it. There is a need for Black psychiatrists. There's a need for Black physicians that can handle people in crisis from multiple different angles, whether it be through, you know, through the criminal justice system, through medicine, like it's all needed. And so I think that really addressing this issue head on and being aware of it is priority number one, but then also creating safe spaces for Black physicians so that they'll want to continue to stay in psychiatry over a long period of time. So having Black mentors, or, you know, and just having white allies that when a patient says something, you know, racially charged to a Black physician, just checking in, like that's just a very basic thing to do that really just says, hey, I care and I'm here for you, and what you're doing is important. I think something that I touched on in my talk as well is incentivizing people to go out into the communities. I really cannot emphasize enough how important our community health centers are, such as Southeast and North Central, of really just getting connected to that population of people that may not otherwise have access to care.
Mm-hmm. I think that one of the major points you made that I just want to reiterate was that just showing up, you have to show up. Like even if you're, I think sometimes people don't because they're afraid of saying the wrong thing, or they don't know quite what to say. But I think when something like a racist patient attacking a Black physician or a Black student happens and no one shows up, that just increases and amplifies the damage. So I think just wanted to repeat that because it definitely bears repeating. Here's another question. As a follow-up to Dr. Gur's question, if it it isn't answered now, which it hasn't been. What is the role of non-medical or non-psychiatric researchers in helping improve patient outcomes? I work in social psychology, public health, gender studies, etc., and I'm always excited for opportunities to do research that affects providers and patients. Do you think psychiatrists are generally open to collaborating with researchers from other areas?
I would say yes, but I think that often they are not approached enough by people, or conversely, we don't make the effort to be as collaborative as we could be. Generally, the vibe I've gotten from psychiatrists is that we're really in love with the field. And by nature, our jobs are collaborative. So every day, at least on inpatient rounds, we're rounding with social work, we're rounding with pharmacy, we're rounding with nursing. That's just the name of the game. And so I absolutely think that psychiatrists are and should be more open to collaborating with people that are interested in that. I think any research helps, especially when it comes to public health and more macro scale structural issues.
Yeah, I would agree with you. There's questions are pouring in, so I'm just going to continue asking for time. Are there any efforts to partner with libraries or other community centers to provide space for telehealth for patients without transportation or internet access?
You know, that's a really good question. I don't know necessarily locally if there are. I know that there's been some incentives within, at least when I was looking up kind of like the situation with telehealth, of trying to get people like tablets or phones within like homeless shelters so that they can make their appointments. I know that's the case, but I'm not sure about libraries, especially with COVID, like some libraries are closed, so I don't know.
I know that local public libraries have made Wi-Fi available in their parking lots, so that, but again, that you would need a car, so that for people to assist with homeschooling, but I don't know.
Yeah.
That's the only thing I know of as far as libraries. But the next question is, do you think OSU College of Medicine does a good job of acknowledging and educating medical students regarding the health issues and disparities that Black individuals face in the LSI curriculum? If not, how can we advocate for improvement? That is a great question.
It's a good question. I got to put on my student council hat and my psychiatry hat. You know, I think that we're getting there. I think there's always room for improvement, obviously. And I think I will say, I think that it is improved since I was a first-year medical student. I think the work that minority student organizations at this school have done, it's unparalleled. And I think that supporting those organizations such as SMA, LMSA, et cetera, in their pursuits and trying to incorporate these things within the curriculum. But also student council helps. The Diversity Inclusion Committee is here. If you have feedback about specific lectures or things that you want done, please feel free to contact me. But I know that as part of the Anti-Racism and Equity Task Force, there's a more macro plan, I think, that will happen over the next few years to try to really hone in on gaps in the curriculum when it comes to these kinds of issues and addressing these disparities in a more holistic way.
It's a very thorough answer. Thank you. Here's more questions. In your experience interviewing for residency, have you found that programs have a recognition of this problem and are actively working to address it?
I think in psychiatry, yes. I can't speak for other fields, but I think in psychiatry, they've made it a priority. I know the APA specifically has made wide statements about specifically residency recruitment and trying to recruit more Black physicians and addressing these racial disparities that exist. So I don't know. I'm biased because I love psychiatry, but I think that everyone's done a pretty good job of trying to address those head on.
I'm now getting questions in two places, but someone says, as a side note for students interested in advocacy, this is a big area for moving forward. Wi-Fi should become a more accessible resource to all people as society becomes more technologically reliant. There are folks working on policy that would expand Wi-Fi access. That's from Emma Barrett. You're getting lots of thanks and we need to collaborate and an amazing presentation notes. Here's the last question I believe we have time for.
Okay.
Thank you for this great presentation. Earlier, you mentioned that BIPOC or BIPOC patients are more likely to be religious. How does religion serve as a factor to mental health and to psychiatric health administration? That is a great question. You guys are asking, I think I've been to a million webinars during this pandemic and you guys are doing the best.
I agree. That's really interesting. I hadn't seen like a lot of research into that, but I think the thought behind it is that, you know, there's a lot of different ways people cope, and that religious bond that people have, or like religious coping mechanism, is their way of, I guess, finding, social support. It is seen as a factor that contributes to resilience. It may not be a mode that obviously that everybody uses or that people understand, but it is shown to really help. And I know in the inpatient setting, at least psychiatry does ask if people are religious, because when people are dealing with terminal illnesses or really difficult physical health situations, we try to ask about what their coping mechanisms are. And if religion is one, we call the chaplain and try to figure out how we can best allow that patient to cope with their illness.
Mm-hmm. And actually, they've started to do some brain imaging studies of prayer and religion, and they were finding some very interesting things about just exactly how the brain lights up with prayer, and it's activating a lot of the same brain regions as other coping skills. And so it's definitely an active neurological process or neural.
Oh, that's cool.
It's some very neat work, but that really was a tour de force, and you've done a phenomenal job, as I knew you would. Congratulations on an amazing grand rounds, and congratulations to the organizers for, again, one of the best webinars I've attended this whole panoramic situation.
Thank you, Dr. Gore. Appreciate it.
Thank you so much, Dr. Gore, and thank you, Charissa, for the phenomenal talk. The QR code is here for all of our participants to go ahead and provide feedback, both to Charissa and to our medical student grand rounds series. Also a reminder that starting in March, on March 2nd, our next medical student grand rounds is going to feature the deans within the College of Medicine talking about the state of education and talking about kind of the future of the College of Medicine. So we're really excited for that, and we hope that you are able to join us. Again, Charissa, thank you so much. Thank you for giving us your time and your experience, and thank you, Dr. Gore, for being with us as well.
It was an honor. Thank you so much.
Thank you for having me. Take care.